Hello, everyone. My name is Dr. Troima. I am the ECFMG and LMCC Licensing Exams Program Director at Edge Plus, and it's my pleasure to showcase two examples to show you our teaching strategy at Edge Plus and how we facilitate and help um, your preparation for the exams. I'm going to showcase you two MCCQE-1 cases. So let us start. Let's see. Yeah. Okay, so I guess you can see my screen now. So this is the first case. It's a COPD case, chronic obstructive pulmonary disease case. So this is a 65 years old man with the COPD. So they already told you in the stem of the question that he has a COPD, comes to the ER with increased dyspnea and worsening cough for the last few days. He has been unable to rest due to increased symptoms. The patient has increased the sputum production compared to his baseline. He tried 3 nebulizer treatments with albuterol and ipratropium bromide at home with no relief. His most recent spirometry during an office visit a month ago showed a forced expiratory volume of the first second, 60% of predicted. His temperature is 37.2, BP 150/90, pulse 100, respiratory rate 23 per minute, and the oxygen saturation is 87% on room air. He appears to be in mild respiratory distress. Lung examination shows bilateral wheezing, prolonged expiration. ECG shows sinus tachycardia. Chest X-ray shows flattened diaphragm, no infiltrates. Initial lab studies, white blood cell count 11,000. Started on supplemental oxygen, bronchodilators, glucocorticoids. So which of the following additional therapies will benefit this patient in this acute setting? That's the question. The answer choices: antibiotics, chest physiotherapy, fluticasone inhaler, magnesium sulfate, no additional therapy. So, in your opinion, which one is the correct answer? Is it the antibiotics, the physiotherapy, the fluticasone, the magnesium sulfate, or no additional therapy? And the correct answer is, or is it the roflumilast? And the correct answer is antibiotics, A. Now, why antibiotics? So, as I have previously explained in my previous in my previous showcases, our strategy at Edge Plus is based on analysis of knowledge driven. So we have to go back to the case and then analyze it, and then pull from it the keywords that we will link to our knowledge base, which we get from Turn Notes. And by linking the keywords to the knowledge base, at this point, we will be able to see the correct answer. So let's go back to the case. So what are the keywords that we will be looking for? First of all, the risk factors. So any case, you have to look at the risk factors for it. What are the risk factors for this patient? That he's a smoker, he's 65 years old, he's a male, he's a smoker. They told you that he has already diagnosis of COPD, comes to the ER. So ER, that's a hot setting. So that's an emergency case. It's a hot case. Presentation: increased dyspnea and worsening cough. Increased dyspnea and worsening cough for the last few days. Okay. And he's unable to rest. He tried 3 nebulizer treatments at home with albuterol and ipratropium with no relief. So this means that this patient is having now a refractory presentation, refractory or acute exacerbation of the COPD. Forced expiratory volume of the first second is 60% of the predicted, respiratory rate 23, oxygen saturation is 87%. So if you're having a refractory presentation or a refractory acute exacerbation of COPD, refractory to the nebulizations, he tried three sessions of nebulization with no response, and the oxygen saturation is low, 87%. So this means we need to add something else, or we need to give additional medication to this patient to improve his respiratory status. Physical examination findings: bilateral wheezing, prolonged expiration, sinus tachycardia, and the chest X-ray shows flattened diaphragm and no infiltrates, meaning that no infiltrates. So they gave you this trying to trick you. So by telling you that there are no infiltrates, this means that there is no chest infection by the chest X-ray. He started on supplemental oxygen, bronchodilators, and glucocorticoids. So this is a case. This is a case of acute exacerbation of COPD. Cardinal symptoms for acute exacerbation of COPD: increased dyspnea, increased cough, or increased sputum. Increased cough meaning more frequent or more severe, increased sputum changing in volume or color. Mild acute exacerbation if only one out of the three cardinal symptoms is fulfilled. Moderate if two out of the three, that's to say either increased sputum purulence and increased cough, or increased sputum purulence and increased dyspnea. And severe if all the three cardinal symptoms are fulfilled. Chest X-ray shows hyperinflation, and ABGs show hypoxia, carbon dioxide retention. So either a chronic carbon dioxide retention with PaCO2 more than 45 and pH more than 7.45, or acute hyperinflation with a PaCO2 more than 45 and the pH less than 7.35. Management of acute exacerbation of COPD: supplemental oxygen, and your target SpO2 should be 88 to 92%. Inhaled bronchodilators, systemic glucocorticoids, antibiotics if moderate or severe acute exacerbation, like our case, oseltamivir if there is evidence of influenza, non-invasive positive pressure ventilation, or NPPV if there is respiratory failure. Tracheal intubation if the NPPV failed or is contraindicated. Contraindications for the non-positive pressure ventilation include what? Cardiac or respiratory arrest, non-respiratory organ failure like severe encephalopathy, severe GI bleeding, hemodynamic instability with or without unstable angina, facial surgery or trauma, upper airway obstruction, inability to protect the airway, and or a high risk of aspiration. Also, inability to clear secretions. Antibiotics are usually given for moderate and severe acute exacerbation of COPD. Sputum culture and sensitivity is not recommended before starting the empirical antibiotics in community setting, except in patients with risk factors for community-acquired Pseudomonas aeruginosa, like what? Like compromised immune status, recent prior antibiotic use, structural lung abnormalities as bronchiectasis or cystic fibrosis, or a history of repeated moderate or severe acute exacerbations of COPD requiring frequent glucocorticoid use and or antibiotics. Empirical antibiotics should cover the common upper respiratory tract bacterial pathogens as Haemophilus influenza, Moraxella catarrhalis, strep pneumonia. They're given for 3 to 7 days, and they include macrolides as azithromycin, fluoroquinolones as levofloxacin or moxifloxacin, penicillin beta-lactamase inhibitors as amoxicillin clavulanate. Antibiotics given in moderate to severe acute exacerbation of COPD: mechanical ventilation, endotracheal intubation, and or NPPV, chest physiotherapy, percussion vibration, other mechanical techniques given for bronchiectasis, inhaled glucocorticoid, fluticasone. This is given as a long-term management of asthma and or COPD. Magnesium sulfate given for acute, severe, life-threatening asthma exacerbations. And roflumilast given as a maintenance therapy of COPD. So this was our first case. Let me share with you the second case. Yeah, there it is. So this is an OB-GYN case, an obstetrical case. A 33 years old female, gravid 1 para 0, 27 weeks gestation, comes to the office for prenatal visit, recently immigrated to Canada from Italy, ultrasound, 8 weeks gestation, confirmed pregnancy a few weeks ago, fever, diffuse non-pruritic 2-day maculopapular rash, resolved spontaneously without intervention. Vital signs are normal. Fundal height is 23 centimeter. Now take care, fundal height is 23 centimeter. Now take care of the discrepancy between the fundal height and the gestational age. Gestational age is 27 weeks and the fundal height is 23 centimeter. Fetal heart rate 160, transabdominal ultrasound showed bilateral ventriculomegaly, multiple intracranial basal ganglia calcifications. In addition, transabdominal ultrasound showed ascites, hepatomegaly, and the estimated fetal weight is below the 5th percentile. So these are the keywords collected for you. So the differentials that you may think of, this is typically, like this is an infection during pregnancy for sure. So infections may include toxoplasmosis, rubella, CMV, herpes simplex, parvovirus B19, varicella zoster, chlamydia trachomatis. These are the common infections that can occur during pregnancy. The question is, which of the following is the most likely pathogen causing this fetal infection? Is it herpes simplex, chlamydia, toxoplasma, varicella zoster, parvovirus B19? And the correct answer is toxoplasma. Okay, so going back to the case quickly and collecting the keywords. So as mentioned, this is 33 years old, female, gravida 1 para 0, 27 weeks gestation, and now presenting with an ultrasound at 27 weeks, but the fundal height is 23 centimeters. So there's discrepancy between the gestational age and the fundal height. In addition, a few weeks ago, she had fever, non-periodic rash. So fever during pregnancy and the rash, for sure, this indicates infection. Resolved spontaneously, fundal height 23 centimeter, ultrasound at 27 weeks, bilateral ventriculomegaly, basal ganglia calcification, and the fetal weight is less than the 5th percentile. Okay, how do we differentiate? So maternal fever, non-periodic maculopapular rash, fetal bilateral ventriculomegaly, basal ganglia calcification, growth restriction, that's congenital toxoplasmosis, other infections during pregnancy, chlamydia, transmissions during delivery, neonatal conjunctivitis, neonatal pneumonia, congenital rubella, maternal periuretic maculopapular rash, fetal intrauterine growth retardation, atrial septal defect, cardiomegaly, congenital varicella zoster, maternal chickenpox, which will show up with periuretic vesicular rash, fetal lymph aplasia, hydropus fetalis, congenital herpes simplex, maternal painful genital ulcers, fetal placental umbilical cord and temporal lobe calcifications, congenital cytomegalovirus, so this will show up with fetal ascites, hepatomegaly, fetal periventricular calcifications, and hyperechogenic bowel. Congenital parvovirus B19, this will show up with fetal anemia and hydropus fetalis. So thank you for listening to me and for enjoying these two showcases. Hopefully you will, I wish all of you the best in your journey to prepare for the MCCQE-1 exam. We are always there for you to help you and support you. Thank you and see you soon.